I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi, everyone, and welcome to the July 2018 edition of the PRS Journal Club podcast. I'm Ira Savetsky, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh Medical Center and Nicole Phillips from the Harvard Plastic Surgery Program. Today, we have the great honor of being joined by Dr. William Hoffman, Professor and Chief of Plastic and Reconstructive Surgery and Vice Chair of the Department of Surgery at the University of California, San Francisco Medical Center. Thank you so much, Dr. Hoffman, for joining us for this PRS Journal Club podcast.
Thank you. It's my pleasure.
A quick reminder, all of the articles that we will discuss can be read for free on PRSjournal.com, including an archive of all past Journal Club articles. The article we'll be discussing is, Do Adolescents with Gynecomastia Require Routine Evaluation by Endocrinology? By senior author Dr. Jukpal Arneja from the University of British Columbia. To begin, gynecomastia is abnormal breast tissue in a male patient that typically presents itself as concentric swellings below the nipple areolar complex. Approximately 50% of adolescent males will experience some form of gynecomastia through puberty, with a peak incidence between 13 and 14 years of age. Only 5 to 10% of gynecomastia persists beyond 1 year. The cause of gynecomastia is a disturbance in the balance between the sex hormones testosterone and estradiol. Not surprisingly, pubertal gynecomastia is often a psychological stressor and may interfere with social maturation. Treatment options can be divided between non-surgical versus surgical, depending on severity, comorbidities, as well as the psychosocial impact on the child. Non-surgical options can be watchful waiting and/or lifestyle modification. Medications that target estrogen are a potential option, although recurrence can occur and high-quality evidence is lacking. Surgical management is typically performed with liposuction and/or direct excision. The often transient nature of adolescent gynecomastia, along with the psychosocial stress on an adolescent, makes the treatment plan and management particularly challenging. The controversy in the literature that exists, which the authors try and answer, is whether or not there is utility in undergoing endocrinology evaluation in pubertal or persistent pubertal gynecomastia. Some advocate getting serum levels of testosterone, estradiol, gonadotropins, karyotype if testicular volume is less than 6 ml. Others advocate getting lab and endocrine referral if there is a rapid development of gynecomastia or if breast tissue is greater than 4 centimeters. The common factor is that there is an emphasis on a good history and physical exam in guiding investigations, but there is little consensus around endocrine evaluations. The authors state at their institution at British Columbia Children's Hospital, adolescent patients presenting for gynecomastia management are seen by pediatric endocrinologists and endocrine investigations are routinely ordered. This was a 26-year retrospective review conducted on patients presenting to their institution from 1990 to 2015. Patients were included if there was a diagnosis of gynecomastia, an age of first consultation less than 18 years old, and at least 1 year follow-up after the first assessment. 200 patients met these criteria. In terms of outcome, their primary outcome measure was the utility of endocrine consultations for gynecomastia. Treatment outcomes were classified into 3 categories: observation, medical management, and surgery. A tertiary outcome was the case cost of the endocrinology investigations and consultation. In terms of results, 197 patients met inclusion criteria. The median age of gynecomastia onset was 11.5 years of age. The median age at first endocrine consult was at 14 years. There was psychosocial morbidity documented by the clinician in 71% of cases. Marijuana usage was reported in 5% of the cohort, and 15% of the cohort had a positive family history of paternal gynecomastia or maternal breast cancer. There was at least one comorbidity in 18% of the total cohort. Physical examination findings noted that 50% of patients were overweight or obese. Unilateral and bilateral gynecomastia was reported in 20 and 80% of patients respectively. The median testicular volume was 12 mLs bilaterally. Onset of gynecomastia was pre-pubertal in 25 patients based on a testicular volume of less than or equal to 3 mLs. At first consult, 47% of patients had testicular volumes consistent with normal puberty between 3 and 15 mLs, and 37% were post-pubertal with testicular volumes greater than or equal to 15 mLs. Following 197 endocrine consultation, 80% of the cohort had blood tests. A total of 92% were diagnosed with physiologic or pubertal gynecomastia, and 8% of patients were diagnosed with secondary gynecomastia. Of these secondary diagnoses, 10 were related to exogenous substance uses, including marijuana and medications that are known to cause gynecomastia, such as risperidone, spironolactone, and fluoxetine, among others. Other secondary cases included a patient with low testosterone, secondary to metabolic syndrome, one with an enzyme deficiency, and one with testicular hypoplasia, and 3 with genetically confirmed Klinefelter syndrome. 3 of the 15 patients diagnosed with secondary gynecomastia had biochemical evidence of an underlying hormonal disturbance. Out of investigations ordered in 173 patients, this represented only a 1.7% biochemical yield. In terms of treatment and outcomes, 51% of the cohort received no medical treatment following consultation and were counseled on either watchful waiting or diet and exercise to reduce their BMI. The median age of gynecomastia resolution was at 14.5 years old in patients that received no treatment. 44% of the cohort was referred for surgery, and 5% of the patients were treated with medications only. The median age of surgery was 16.5 years old. In terms of costs, the gross estimate that incurred through consultations and biochemical workup was a total of 67,000 Canadian dollars, and this was equivalent to about a case cost of about a little less than 400 Canadian dollars. The authors go on to do subgroup analysis based on pubertal gynecomastia, unilateral gynecomastia, in patients with an elevated BNI. In the interest of time, I won't review their findings, but there was no significant statistical relationships found. Overall, I think this was a really good study. They did a great job analyzing the role of endocrine workup, including biochemical investigations, in the evaluation of adolescents presenting with gynecomastia. I think this is a common question that comes up when I'm evaluating or seeing a patient for the first time, whether or not we should be referring to endocrine to get further workup or to draw labs. They found that endocrine workup is actually a low yield component of the workup, and that these investigations did not yield new clinical information over 99% of cases. They provide good evidence that adolescents presenting with persistent pubertal gynecomastia or for preoperative assessment should neither be routinely evaluated by routine endocrine consultation nor screened with routine testing. Only when a patient exhibits signs of endocrinopathy, an abnormal testicular exam, Klinefelters, or known medications, or pre-pubertal onset should an endocrine referral be made. They also indicate that the majority of secondary gynecomastia diagnoses were iatrogenic, and again, the importance of a thorough history, particularly a comprehensive medication review, in addition to a testicular examination, is critical. Dr. Hoffman, I'm curious to hear some of your thoughts about this paper. What is the practice, as far as you know, at your practice or at your institution in obtaining endocrine evaluation? And do you see this paper having an impact in your practice or in your institution's practice going forward?
I think this was actually a really good paper, and it's answering a good question. In fact, thinking back on it, I'd see maybe 10 or 12 gynecomastia cases a year, something like that. And in fact, we do routinely get endocrine labs, but I can't remember maybe ever having any positive findings. So it actually makes perfect sense. You'd have to rewrite some of the books, I think, in order to change guidelines. But the one thing that would be useful, it would be you'd meet a much larger number of patients, but it would be nice to know in the patients who do have positive findings in terms of their lab work, what the physical exam was and what would be the criteria that you would use to order endocrine labs. Obviously, if you did a testicular exam and it was abnormal, that would be one, or some other things like that, but that would be a useful adjunct to this.
I think those are great points, and I think what we were discussing in our other paper about cleft lip, again, as we are becoming more cost conscientious, I think these papers are important as we obviously want to utilize our resources as efficient as possible, and certainly in Canada, given their healthcare system, it's emphasized even more so. Francesco, what were some of your thoughts about this paper?
I agree with what you guys have said. I think the authors did a really good job with the research question they bring forward, a very interesting question, which honestly I haven't really thought about because I feel we focus so much, especially as residents, on the surgical aspect of these cases, since you can rely on your medical colleagues to ensure that other causes like secondary gynecomastia are ruled out and so on. However, I think that 7.6% of diagnosis of secondary gynecomastia is still, kind of on the higher side, and would reinforce my willingness to perhaps seek input from endocrinology or just make sure that we're covering all our bases. Because the truth is, I don't know how many plastic surgeons would conduct a neurological examination or fundoscopy examination as recommended by the authors. I will say that in principle, I agree that the evidence is compelling, but I'm not sure in practicality how many plastic surgeons will stop ordering labs or referring to endocrinologists. And so also another interesting point is that the majority of cases are due to exogenous substance abuse, as detailed by the authors. And if so, Dr. Hoffman, should we consider screening patients for the most common exogenous substances, even if they are not mentioned during the HNP?
Well, it's a majority of what they called secondary gynecomastia, which was a term that I didn't really understand very well, but it was only basically 10 patients out of almost 200. So you're absolutely right, though, and there's some question about whether marijuana really does cause gynecomastia, but it is obviously difficult thing to bring up because the patients are always there with their parents. And so you have a 15-year-old kid and you go, you're not going to ask them if they smoke pot because they're going to say no if their parents are there, no matter whether they do or not. And in California, I would bet that it's at least 50%, maybe more. And so it's hard to figure out. I think the bigger problem is the patients with obesity. They didn't all get surgery, obviously, but the patients with obesity are always the problem in terms of making decisions about surgery because really they should lose weight. And there's always this back and forth that, well, they won't work out because they won't take their shirt off. It's certainly if somebody's really morbidly obese, they need to lose weight first and not have surgery for their gynecomastia because it's probably more fat than actual breast tissue.
Absolutely. These are great points. Thank you so much, Dr. Hoffman. Nikki, what did you think about the paper?
Well, I think that sort of leads us into, one of the interesting aspects of it, which is all the psychosocial stressors around it. And certainly it's tricky and challenging to counsel an adolescent on their weight and weight loss. And I also think, as we all know, the management for this is really wait and see for a while because the majority of cases will self-resolve. One of my questions, Dr. Hoffman, is, what resources can we provide to patients and their families to help them through that sort of wait and see period? Is there counseling we can provide to them or weight loss programs? What are your thoughts on that?
All the above. I think with the obese patients, for sure, we have an adolescent weight loss program that I refer patients to. Again, we were talking earlier about the geographic problems, and so if they come from far away, it can be a difficult thing to get them to come to things where they meet every week and go, and have a program. It can be tough to necessarily get to the hospital for that stuff. I think counseling is certainly useful. And I think that to some extent the promise that, if it doesn't get better in a certain amount of time, that you can fix it, I think probably helps them psychologically to some point, at some extent as well. In California, I don't know about everywhere, but the insurance companies we deal with all actually insist that a patient be at least 10 or 4 or 5 for 18 months before they will approve any gynecomastia surgery. So they have basically enforced a wait and see period because they won't cover the surgery otherwise.
There's something that's actually nice about having guidelines like that in place occasionally from insurance companies or from external institutions where you can say, listen, we have to wait this period of time because, these are the rules. And I think that sometimes can make counseling patients a little easier as well.
Absolutely.
Ira here. I think that, this paper really highlighted some interesting and key findings. Even if we were to sort of leave here after this podcast, say, okay, we're not going to waste money and time ordering labs. I think part of the problem is that these patients are typically referred by their pediatricians, or their pediatricians will see them. They'll either send the labs out themselves or they'll send for endocrine evaluation prior to even showing up in our office. In the paper, the authors report referrals to endocrinology department from plastic surgeons in only 10% of the time, where the remainder of the referrals came from primary care physicians, such as family medicine and pediatricians. I'm curious to hear, Dr. Hoffman, how often are patients showing up in your office, with already having gone endocrinology evaluation? And is there anything we could do to help streamline or change sort of the referral pattern, change the environment of the current referral pattern?
If I had to guess, I would say that it's maybe about 50-50, whether they come in with labs already or not. And I think ultimately it's about education, and maybe to some extent it might be our job to educate the pediatricians when we have data like this. One avenue for that is the Academy of Pediatrics. There is a plastic surgery section of the American Academy of Pediatrics. It's a relatively small group of like 100 people. These are the pediatric plastic surgeons in the country. I chaired it several years ago, and it rotates through every 2 years. We get a new chair. And we, as fellows of the Academy of Pediatrics, we get talking time at their national meeting. And it's often that we're asked to propose courses, and we teach courses at the National Pediatrics meeting every year. And this might be a good topic to have as a educational topic where you could show what surgical results are, but also talk about the workup and maybe start to disseminate this kind of information.
Yeah, I think that's an excellent point. And I think sort of what Francesco mentioned earlier, you know, as residents, we're so focused on trying to plan and execute the right operation that sometimes we're not thinking about big picture. But I think those are some really great comments, and I think it was a great discussion. And I think with that, we'll end the discussion of this article. Thank you again, everyone, for this discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Also, remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and is there where our monthly journal club takes place. And once again, thank you so much, Dr. Hoffman, for joining us. It's been a great pleasure.
Thank you. It was a lot of fun.